Neurology and cardiology, along with qualifications in pulmonology and general medicine. So please come on to the stage and join us as a panelist for today's session.
It is also my privilege to invite Dr. Sivanarayana Gopalam, a distinguished neurophysician with over 3 decades of experience in neurology, currently practicing at Girija Neuro Center, Vijayawada. He is regarded as one of the most eminent senior neurologists, well known for his dedication and service to the field. I request Dr. Sivanarayana Gopalam to kindly join us on the session as a panelist for today. Thank you, sir.
I request Dr. Rajesh Polavarapu, a consultant neurologist at Aster Ramesh Hospitals, Vijayawada branch, to moderate the session. May I request Dr. Pragna Sree, DNB Neurology, to present the topic.
Good afternoon, everyone. Now I'm going to present 2 cases on headache. And speech were normal. The cranial nerve examination, the fundus examination showed bilateral papilledema. Rest of the motor, sensory and cerebellar examination was normal. This is an MRI brain showing prominent CSF spaces along the bilateral optic nerves with tortuosity seen in both the optic nerves. And this is the MR venogram of the patient showing hypoplastic left transverse and sigmoid sinus. MR angio was done, which was normal. And lumbar puncture was done, and which showed an opening pressure of 26 centimeters of water. Coming to the second case scenario, a 24-year-old female presented with a 3-week history of headache and blurring of vision. Headache was initially holocranial and throbbing type. She had associated symptoms of photophobia, diplopia, which was binocular, constant and horizontal. She also had tinnitus and nausea. The past medical history, she had a history of irregular menstrual cycles for which she had been placed on oral contraceptive pills. And the symptoms started around the same time when she commenced using the OCPs. And she had no other significant family history or no comorbidities. Her clinical vitals were normal with a weight of 97 kgs and her BMI was 34.4. And neurological examination, the cognition and speech were normal, and the fundus examination showed the optic disc revealed marked papilledema of recent stage 4, and rest of the neurological examination was normal. This is a fundus image of left eye showing the elevation of the entire nerve head and obscuration of all borders with the peripapillary halo. And imaging was done. This is a T1 sequence showing the vertical tortuosity of the optic nerve and with flattening of the posterior segment of the globe. This is MRI sequence, sagittal view showing the empty sella turcica and posterior displacement of the pituitary stalk. And CSF analysis was done again, which showed normal protein glucose and but a higher opening pressure of 20.
Yeah, good afternoon, everyone. Yeah, I don't want to get you a postprandial headache now. So before going to that, panelists, can have any insight into the cases?
So, both of them have an increased CSF pressure.
Yes, sir.
What is the first line of management that we planned in these patients? What was the thing you did first?
Sir, actually, we would like to rule out this is a diagnosis of exclusion, sir, as you come to diagnosis. So, first thing is, in both the cases, childbearing women with classical symptoms in the first case and atypical symptoms in the second case. So, post that, both were treated with CA and inhibitors. And later on, both were have good vision improvement is there, sir, with the treatment.
Did you continue? How did you follow these patients? Because now
Yeah, that is the perimetry, sir. First thing is visual perimetry has been done. That's why I asked ophthalmologist also to attend here.
So, what are the ophthalmic things, sir, that you consider as a differential diagnosis in these patients when they come?
So in both these cases, there is rare intracranial pressure, and that can lead to papilloedema. And in fact, if you here you have not showed the visual field.
Yes.
What is the type of visual fields you got it done?
Actually, there is a peripheral vision loss, sir. Both the cases were sent to us by an ophthalmologist.
Yeah.
So that's why we didn't get the copies.
So usually raised intracranial pressure can lead to generalized constriction of the visual fields, bearing of the we call it the bearing of the blind spot, and then even if you see the vision, it will be 6 by 6 only. Vision will not be affected, but when you see the fields, the peripheral constriction will be there. So the moment you start the treatment, and they will come to the normal position. Especially the optic disc edema, the papilloedema. The moment you start the treatment, it takes some time to come to the normal visual fields. The peripheral isometric contraction of the fields, the peripheral fields, you will have a constriction.
Yes. So here I have differentiated like ophthal cases on your left side and pure neurological cases on the right side. That is migraine variants, hydrocephalus, intracranial epidural abscess, leptomeningeal carcinomatous Lyme disease, as well as subarachnoid hemorrhage. So other conditions like ophthal conditions like pseudopapilledema, drusen of the optic nerve heads, malignant hypertension, bilateral infiltrative or infectious or inflammatory optic neuropathy, and bilateral anterior ischemic optic neuropathy, and bilateral optic nerve papillodes. So main thing is the risk factors for this case, as you came to know this, the diagnosis is IIH, idiopathic intracranial hypertension. So before coming to this diagnosis, I need to exclude all the other differentials for the IIH. So for all the differentials like primary headaches as well as the secondary headaches, then come to a diagnosis of IIH. So for IIH, the risk factors include the medications. We need to see overdose of medications like tetracyclines or cyclosporin or lithium nalgesic acid, nitrofurantoin or OC pills or levonorgestrel and tamoxifen, and endocrine abnormalities such as corticosteroid withdrawal, anabolic steroid, excessive growth hormones, and thyroid disease. And most vitamin is vitamin A excess or deficiency, and systemic conditions such as pregnancy, menstrual irregularities, PCODs, even anemia, obstructive sleep apnea. These are all associated with IIH. So this is the modified Dandis criteria, where IIH is criteria includes one is papilledema and normal neurological examination except sixth as well as seventh cranial nerve pulses can be accepted. And next is neuroimaging like normal brain parenchyma, and venous thrombus has to be excluded, and normal CSF constituent should be there, and elevated lumbar pressure at least greater than 25 centimeters of water should be there. And there is another entity that is IIH without papilledema also can be there. So in there unilateral or bilateral sixth nerve cranial nerve palsy along with other from B to E are present. So in presence of ophthalmologist here, I would like to discuss about fundoscopy, how important the fundoscopy in a clinic by a physician. This is the modified Frisen papilledema scale. Grade 0 is a normal optic disc, that is a prominence of the retinal nerve fiber layer at the nasal superior and inferior poles in the inverse portion of the disc's diameter, and radial nerve fiber layer striations without tortuosity. And grade 1 is a minimal degree of edema. There is a C-shaped hollow that is subtle and grayish with a temporal gap that obscures underlying retinal details. And grade 2 is a low degree of edema, that is a circumferential halo will be there with elevation over the nasal border. And there is no major vessel obscuration here. So these are the grade 3, 4 and 5. Grade 3 is a moderate degree of edema where the obscuration of greater than or equal to one segment of major blood vessels while leaving the disc will be there. Here the arrow is pointing where the vessel is leaving the disc. So there you can see the obscuration of that vessel. And grade 4 is the marked degree of edema. There is a total obscuration on the disc of the segment of a major blood vessel. On the disc itself, there is obscuration of the vessels. And grade 5, you can see all the vessels are obscured. So coming to red flags for any headache case, so if there are any systemic signs like fever or other symptoms like secondary causes like if a patient is having HIV, or N stands for neurological symptoms like any confusion, any neurological deficits, or any sudden onset of a headache in an older person that is greater than 60 years of age with a progressive headache. And if there is any change in pattern of headache or any other precipitators along with papilledema, then a physician has to ask the patient to see the neurologist, particularly to rule out IAH or any other secondary causes of headache. So this is in brief approach to the headache. So we need to evaluate the red flags as I said before, and we need to rule out the primary cause of the headache, particularly migraine, tension headache, and trigeminal autonomic cephalgias. And later I need to rule out any secondary causes like infectious causes, vascular causes, and any structural tumor trauma related causes, and any other like sinusitis, and finally come to a diagnosis of IAH. So my take home message is not every headache is a migraine or anything. We need to rule out all the other causes. Headache is the most common and often the disabling symptom of IAH, and early diagnosis and treatment are key to preserving vision and improving quality of life. And any worsening of new visual symptoms should be evaluated immediately to prevent irreversible damage. Thank you.
Yeah, here I would like to add this a little bit subject to the Dr. Rajesh presentation. Neuroophthalmology is one of the real fascinating subject even when we were residents. So because the visual pathway involves all the lobes, almost parietal, temporal, occipital lobes, the entire, most of the parts of the brain are involved in as far as the visual pathway is concerned. Regarding papillary edema, just because of raised intracranial tension, there will be edema. As you said, the staging is the last stage. There may be involvement of the vision, but in initial stages, when you see the papillary edema, the vision will be 6 by 6. Stage 1, stage 2, stage 3. That is the most important differentiating point between the papillitis and then papillary edema. Simple papillary edema, patient will have good visual acuity, 6 by 6 or 6 by 9, unless the macula is involved. And whereas papillitis, definitely, even in the beginning itself, when there is compression at optic nerve, optic tract, optic chiasma, lateral, anywhere compression with some pathology, vision will be really very, there will be decreased visual acuity. This is the basic difference. And as far as the papillary edema, observation of the papillary edema with the help of direct ophthalmoscope or indirect ophthalmoscope, it should be the practice of a basic physician, not only the neurologist, neurosurgeon. So they should be able to differentiate normal disc with that of the papillary edema, raised disc. You can measure it in terms of disc diopters, 1 diopter, 2 diopter, 3 diopters. We have a lot of findings when there is papillary edema. So these two important points, that is about the visual acuity and then the level of the lesions. You can, if you go for visual fields, definitely there will be some defects, homonymous hemianopia, quadrantic, pie in the sky, macula sparing. So depending upon the visual lesions also, we can guess where is the problem. In case of idiopathic intracranial hypertension, what you are presenting, vision will be normal in these cases, at least in the initial stages.
Thank you, sir.
Any more questions, madam?
So good presentation. So can you have a dual pathology like vascular headache or migraine with IAH?
Definitely, there's a chance.
So you'll be having patients, they will typically present with migraines like headaches, and they will be having AH also.
Yes, ma'am.
But they will, with the anti-edema measures, they won't respond. They will respond to migraine prophylaxis.
For the benefit of audience, does all headache cases need to be imaged?
Not so, sir. It depends on the change of the pattern. As I said, P in the last point, SNOOP P point. So if there is any change in the pattern of headache, which a patient is having a chronic headache, suddenly change it to the character of the headache has been changed, then definitely imaging is required. Otherwise, if you suspect any CSVT, then you need to go for imaging.
For the benefit of PGs, all headache cases should be, you have to go for a fundus examination.
Yes.
Gopalan sir.
So it's even better to screen the patients with CT or MRI, even for the first time of headache also, or with chronic headache also. We see the patients with chronic headache looks like migraine, you'll be finding a chronic tumor like meningioma.
Yes.
So that's better to screen all the patients for headache.
Before going for CT and other imaging test, just even without dilatation, nowadays we are seeing the fundus without applying the dilating drops with the help of 90 diopters length or with the even direct ophthalmoscope. If you see the fundus and if you suspect there is a papilledema, then you can order for the imaging. This is one of the routine screening. It takes just only 1 or 2 minutes to peep through the pupil and then see whether there is any papilledema or not. It takes only just 1 or 2 minutes, and it should be a routine practice for neurologist and others.
I think a thorough history, a detailed examination, and like sir said, fundus examination will clearly tell us whether the patient needs a scan or not. But like ma'am said, you should not be like dogmatic. Okay, history is normal, examination is normal, and I won't do it. Sometimes, like ma'am said, even if history is normal and the examination is normal, but the patient is not responding to medication, in spite of following all the guidelines that you have given, then you have to keep your options open.
Yes.
It's not textbook. It's about prudence. At the beginning, you don't need to do for everyone. But again, just because you don't have the SNOOP criteria, you don't have to be dogmatic about not doing also. Use your prudence to do a scan when it's necessary, when you think. Clinician is the best guideline.
Sure. Sure, sir.
For the benefit of audience, I go by pain syndromes, a mnemonic law. Learn it. Location of pain, exacerbation E, A aggravating factors, R radiation, T N nature of pain, I intensity, and T is timing. I go for all pain syndromes, I will go for learn it, mnemonic.
Okay, we'll proceed with Srikant Vemla sir's presentation.
Thank you so much
Thank
for the informative session, sir. Now I request Dr. Srikant, sir, to deliver an expert talk on precision medicine and the future of migraine management. Over to you, sir.
Good afternoon, everyone. Thank you so much for this chance. I'll be very honest with you. I woke up with a headache today morning. And I knew, just going by